So now we're live over Zoom.
All right, good morning, everybody. I'm gonna ask everybody to find a seat. And we are going to get started. I am filling in for Dr. Devinder Singh. My name is Jason Houtman. I'm the Chief of Neurosurgery. And so we were just talking about this. I came from a place where Grand Rounds was in existence for over 100 years. It's a very important time in which we formally celebrate the academic achievements of one of our faculty or one of our trainees. That to me is holy, okay? Because we all get paid to come and take care of patients. That's the cornerstone of what we do. The academic achievements are almost always above and beyond the clinical care that we provide. And it takes a special kind of drive and commitment to arc that over a career, okay? And that deserves recognition and celebration. And so what I was just saying before we got started is I find it very important that everyone, no matter where you are in your stage of training, you get a formal introduction at Grand Rounds where everyone recognizes what it took for that individual to stand in front of you and talk about years of work that they've done. And that's what I'm going to do for Dr. Peter Chiarelli today. Dr. Peter Chiarelli has been with us for a little shy of a year. I ruthlessly stole him from Children's Hospital of Los Angeles, where he was faculty for about 8 years. The Surgeon-in-Chief still has not forgiven me for doing that. I kind of duck him at national meetings, but unfortunately, Krieger and I are friends. Before that, he was my first fellow when I joined the faculty at the University of Washington. So I've gotten to know Peter for over a decade, and I've watched his career unfold, which makes me very proud. Before he was a neurosurgery fellow in pediatrics, he did his residency at the University of Washington, which humbly is probably one of the best residencies in the country, if not the world, as is the Barrow Neurological Institute, the one that's here. Before the University of Washington, he had an already very storied academic career. He graduated as valedictorian at Pomona College, which is a small college in California. It's a wonderful college. He then went on to become a Rhodes Scholar and did his DPhil, not PhD. I have a PhD. He hates it when I say he has a PhD. He has DPhil from Oxford, where he studied functional MRI under one of the leaders, the functional MRI, Peter Jezzard, right? Yep. And after that, he humbly did medical school at Harvard. We don't say much about that. Peter has done incredible things in the last decade. He's published over 66, 67 peer-reviewed articles. He holds about 6 patents. I don't even understand 5 of them. I've tried reading them. It's very difficult. He's been awarded somewhere in the range of $3 to $4.5 million in funding over that period of time. He holds a prestigious K Development Award from the NIH. He's gotten multiple foundation funds, multiple innovation, intramural and extramural funding. And his work spans 2 very important areas in neurosurgery, though he does a lot more. He'll tell you about that. The 2 that I find the most interesting is he had for many years a basic science lab where he studied nanoparticle delivery for the most difficult pediatric brain tumor, the one that children do not live beyond a year with, diffuse intrinsic pontine glioma, DIPG. It is the glioblastoma of children. It is horrific. We see a handful a year here in Phoenix. No one survives, okay? He's working on that. The other thing that Peter has done an incredible job working on is understanding and advancing our knowledge around hydrocephalus. Hydrocephalus is the most common pediatric neurosurgical condition in the world, the most common neurosurgical condition in the world. You guys have all heard of shunts. One shunt is placed every 15 minutes in this country, and it costs us about $4 billion with a B dollars in healthcare expenditure every year. He's done a lot of work to help us understand and advance our care in the children and adults with hydrocephalus. I'm going to stop talking to come here to hear me talk. But with that, I introduce Dr. Peter Chiarelli, our faculty. He's an associate professor of neurosurgery at the University of Arizona at the Barrow Neurological Institute. He's our friend and colleague, and thank you for coming, man. Appreciate it.
Good morning. So hi, I'm Peter Chiarelli. Let's get started. So this is grand rounds for surgery, and you have a neurosurgeon up here talking about a topic that might not be something on your day-to-day that is super familiar. I want to explain to you guys why it should matter, why it should help draw parallels for the things that you think about, both academically and in the operating room. First, I'll start off with who I am. Jay gave you a little bit of a preview, but I wear two hats. I am both a clinician and I'm also a science nerd by admission. I alternate between those two hats, and the goal of everything that we do academically is to inform what we're doing clinically. So my scientific background, I'm very heartened by the fact that it actually affects what we do clinically. Let me tell you a little bit about the group we put together. And like what Dr. Hauptman had mentioned, this whole talk will be about CSF flow disorders in the brain. There will not be anything about brain tumors in this talk. But our group now, since I made that move from Children's Hospital Los Angeles, our group now spans two institutions. So we have our fledgling cohort here in Phoenix. I've been here since about September. We have our new clinical research coordinator. We have a fifth-year medical student, or a fifth-year resident at Mayo, a number of medical students from University of Arizona, a few collaborators, faculty across Phoenix Children's. And then we also have our existing group at CHLA, which we still fund. So for instance, get my mouse so I can point to things. This is our postdoc, a number of faculty collaborators, which are hugely invested in the work spanning.
He's doing right here. It says laser pointer. This way it'll show up on the screen. There you go.
Oh, thank you. Spanning multiple different departments. So we have collaborators from neuro-ophthalmology, critical care medicine, ED medicine, MRI physics, neurosurgery, neurology, and the like. So let me tell you about what the purpose of our work is. My goal in everything I do in the lab is I want to address problems that actually matter. We want to address neurosurgical problems that currently exist in the world. And rather than spinning the wheels of science, this is about doing clinical investigation and benchtop research that's immediately translatable. The focus of our work is going to be neuroimaging, based on my background in MRI physics. And we will want to look at biomarkers of disease, ways of impacting disease processes that are pretty basic, pretty bread and butter in neurosurgery. And our aim here is to understand the way that the fluid physiology impacts health and disease in the brain. I'll just give you a few acknowledgements just to start off with, so I don't forget later. We have existing funding from this group of places. We've had prior grants from these individuals, and obviously immense support from both our institution here and also CHLA and Keck School of Medicine. So this is really the first slide. What are disorders of CSF flow? Not everybody in this group is intimately familiar with CSF flow disorders on an everyday basis. And actually, more importantly, why do they matter? So disorders of CSF flow actually cause a lot of brain disease. For instance, things like hydrocephalus is a problem with the plumbing in the brain. Chiari malformation, for instance, is you have pretty significant, profound symptoms as a result of blockage of CSF flow through certain corridors in the CNS. Spina bifida, syringohydromyelia, a number of other conditions are really related to the plumbing in the brain rather than the meat. And turns out the plumbing is actually, when it causes a problem, it's actually a pretty big problem. Move my little pointer off this. So just taking one quick step back, as general surgeons or surgeons from other subspecialty disciplines, why should this, I would suggest that you look at this talk through the lens of bread and butter conditions within a surgical subspecialty and doing certain academic activities to impact the care of these really basic conditions. CSF flow, it just so turns out, is actually an international hot topic right now. This is a meeting that just happened over at Yale in March, where our clinical research coordinator, our postdoc, and one of our research assistants, we sent them to this conference. They presented over there. But this is a group of people just doing CSF flow research from across the world. So it turns out that the topic you're about to hear is actually pretty important to a bunch of people. Let me give you one example. Let's talk about Chiari malformation for a few minutes. That's not going to be the focus of this talk, but just to sort of create a sense of what doing certain neuroimaging development projects, how it can impact the way that we look at our clinical conditions that are pretty bread and butter. So for those of you, can you raise your hand in the room if you have heard of Chiari malformation? If you feel like you can explain what it is, good. So I will not re-explain it. Thank you very much. Long and short of it, cerebellar tonsillar descent. There's a fancy jazzy picture here, sagittal of the brain. Here is a little schematic of the syrinx that can result from a Chiari. What you might not be holding your hand as high for is what are the pitfalls and challenges of neurosurgical management? As most neurosurgeons and neurosurgical APPs can attest to, when working patients up for this condition, there is a lot of gray zone. And that's the interesting part, right? Because like I was mentioning before, our research starts with the actual clinical problem that we're trying to solve, as well as the science. This is not developing science and looking for a purpose. This is starting with the problems. And in Chiari management, a big problem is that the type of sequence that we've been using for essentially eons since the beginning, the type of sequence that we've been using to see if the flow patterns of cerebrospinal fluid to and from the craniocervical junction as it's being corked up by the cerebellar tonsil, that imaging has been universally hated between neurosurgeons, neuroradiologists. It's an imaging modality. Here's an example of it, which is based on a cine flow image, which many of you are probably familiar with. We use it a lot in cardiology and cardiac surgery. We use it for this purpose in the brain. But it's a method of imaging that when you look at it, you can't actually decipher what's happening. And then you rely on the radiologist who, when you really get down into it and you ask a radiologist, what does this image mean to you? You'll get a pretty similar response from them. They say, we hate this image. We don't exactly know what it's telling us, but we interpret it nonetheless. If you have interesting questions about cineflow imaging afterwards, I will bend your ear about that, but I will leave that behind at the moment. However, the need in Chiari management was a better imaging technique. And what we had developed was an imaging method that, for all of you guys who can interpret MR pulse sequence diagrams, here you go. This is the imaging technique. It looks fancy, but it's actually really basic. It's a type of flow imaging that's existed for a long time, with complicated parts of the imaging sequence actually taken out. And what it does is it allows you to put a tagged slab anywhere you choose inside the brain. And from that tagged slab, you can then look during a little interval of a couple seconds where CSF moves at that time. So here's an example. Compared to the types of imaging we had before, when everyone in the room looks at this, you can probably see like, oh, yeah, it looks like CSF is moving pretty well in the front on the ventral side, and on the dorsal side, I don't know, but at least I know exactly what's going on. This imaging sequence was so helpful and useful over at Children's Hospital Los Angeles that when I came here and I started doing Chiari management in clinic without the sequence, it felt like I was functioning with one hand tied behind my back. So we immediately ported the sequence over here. Phoenix Children's Neuroradiology adopted it. So this is an imaging sequence we can both get clinically and that we've studied academically. It's also useful for other purposes. For example, this is in a little baby with a workup for aqueductal stenosis. You are physically watching CSF pass through the aqueduct of Sylvius in this baby, which is pretty darn cool. And again, just as a reminder, as you look at this, if you're coming from a subspecialty field that is not neurosurgery, look at this through the lens of what are the basic problems in my field that we don't have current answers to, and how could we possibly tackle them using little tweaks on imaging sequences that already existed? Because again, we did not do pulse sequence programming in order to make these sequences. This is technology that we were able to tweak, to modify, because the science in this field in neuroimaging had advanced just eons beyond the clinical utilization of all of those developments. So it's really interesting to think that in whatever your particular subspecialty field is, there are certain problems that probably already have solutions out there, and matching the problem to the solution, the sort of discussion between clinicians and engineers can lead to a lot of good. So I will go off of that example. Here's one last example in the world of Chiari, where this was a patient that had come in with a car accident. They were having daily suboccipital tussive headaches. They're already known to have a Chiari, but the headaches that they came in with were extraordinarily classic for Chiari symptoms, so much so that they were on the verge of receiving a decompressive surgery. This imaging sequence was performed, and as probably a lot of you in the audience can guess, it showed really excellent flow at the craniocervical junction, which gave the clinicians an opportunity to say, hey, let's hold off on, whisking you off to the operating room. Let's give this a beat. Let's give it a minute, see how the symptoms do, and lo and behold, they entirely resolved. And so this image sequence helped avoid a potentially unnecessary surgery for this one patient, but just having information in general can really help. Here's an example of another child being evaluated for aqueductal stenosis in the brain, where before surgery, you can see, or at least you can make an assessment of whether or not flow is limited through the aqueduct. Before the child received an ETV, this is the area that we actually poke that hole. So if you ever see endoscopic third ventriculostomy on the OR board, and you're like, I wonder what they're doing during those cases, we are making a hole right here. So if you can see where my red dot is, that little flow jet coming out, that is the hole we poke, and it reroutes the CSF for absorption. And then the population of kids who receive this procedure and for whom it works, it is a wonderful procedure. And now you can see the flow actually moving. We went one step beyond. This is my little conclusion to the Chiari tangent in this talk. But we actually went one step beyond in our recent work. So this is work we're doing right now. But in Chiari malformation, we had this realization that, functional MRI exists. Raise your hand if you've heard of functional MRI. This is for my benefit, by the way. I appreciate that hand raising. Functional MRI, where you look at bright lights or you tap your finger, you do a language task. This has existed for a very long time as well, since the early 90s. Functional MRI usually causes your brain to function, to do something. We wondered, in Chiari malformation, the cause of the symptoms is usually from something of a tussive maneuver, a Valsalva maneuver, a cough, a sneeze, little kids taking a poop, all sorts of things that can cause a bearing down motion. Why can't we use that as a functional MRI task? Why can't we put kids in the scanner and have them do a Valsalva maneuver by clenching their abdominal muscles and see what happens? Maybe this could actually be a functional challenge discriminating between individuals with a Chiari who need surgery and who don't. This is an open question right now, but it's a very straightforward approach based on science that had already existed for many years, just modifying it for this condition. So we did this. We created a task paradigm. And this is actually really interesting. You are some of the first in the world to see data like this. But here's an example of a normal individual who does not have a Chiari malformation, as they're sitting in the MRI scan, in the scanner, receiving this type of scan at baseline. And this is what happens when you perform a Valsalva maneuver. So this, if you guys were to clench your abdominal muscles and bear down, your CSF would be shooting up and down your spine, especially look at the scan where the CSF turns bright up in the brain. You shoot CSF every time you bear down way up into your ventricles from your craniocervical junction, which is kind of neat because I don't think people knew that that happens. So we were able to study this. I'm going to put my phone on silent. We were able to study this actually quantitatively, so we can get various quantitative metrics. We can see the difference between CSF flow challenges in Chiari patients and individuals without a Chiari. Needless to say, that's all very academically interesting. I'll show you one last little slide about Chiari before we move on. This is what happens when you Valsalva at the aqueduct of Sylvius. So when you perform a Valsalva, this is without a Valsalva, and then with a Valsalva, your aqueduct of Sylvius creates a little lightning bolt of CSF down into your cervical spine. So neat. Okay, let's shift gears. So hydrocephalus. as Dr. Hauptman had mentioned before I got up here, why hydrocephalus? Did I ever anticipate becoming a hydrocephalus researcher when I was a resident? Absolutely not. I was excited about things that sounded jazzy at the time, like brain tumors and other things. Hydrocephalus is this sleeper topic and really, really important in our field, right? Like Dr. Hauptman was mentioning, this is how we as neurosurgeons save more lives and impact more people in the United States or in the world in general than anything else we do. Not brain tumors, not epilepsy, sorry for all the epilepsy surgeons and craniofacial surgeons in the room, not spina bifida, hydrocephalus. And there are 1 million Americans with hydrocephalus right now. Dr. Hauptman said $4 billion. That is not too far off from my own estimate in terms of medical spending on this condition for readmissions and shunt placements and other things. So it's a life-threatening imbalance, right, between the CSF we produce and the amount we can reabsorb. And I mentioned at the beginning that these are just plumbing problems. We are not doing fancy microelectrode recordings in the brain. We are fixing the plumbing. And shunts, for those of you who just need a quick little refresher, because I know you've all come across shunt patients, they have 3 segments. So there's the brain tube, there's the valve, and there's this other little tube that goes somewhere else in the body, most typically the peritoneal cavity. The incidence of congenital hydrocephalus is high. I already mentioned this 1 million individuals number. Greatest number of lives we save for sure, even though it's not the most glamorous surgery, as we're just plumbers in this instance. And the idea of doing a shunt has been around for a long time. And in fact, quite a long time. These are images from the 1800s of formative shunt designs where this little doodad was shoved into the ventricle, allowing the CSF from the ventricle to communicate to the subarachnoid space. So that's kind of cool. I love shunt history for some reason. I've become like a shunt history nerd. If there was a hydrocephalus show on the History Channel, I would be the dad watching that show. Many shunt styles and valves have been developed. In fact, there's been 200 estimated modifications between 1950 and 2000. Everybody has their own pet project idea for how to make a shunt better. Essentially, our modern design traces back to the 1950s because the plastics that we developed were airplane parts in World War II were actually repurposed in order to make the silastic tubing for shunts. And that's kind of 1952 is when the modern shunt came about. The technology has gotten a little bit better. We now have more flexible tubes. They're coated with antibiotics. They're partially barium impregnated, so you can see them on X-ray. We have valves that you can program or ones that you don't have to program. We got a bunch of fancy doodads for shunts, but the design of the system is about the same as it was before. So this is more or less what I had just mentioned, but now we've got better doodads. But shunts still fail, as everyone who's managed patients on trauma service in the emergency department, anybody who's done collaborative shunt revisions with us, we know that shunts fail, and they can fail at any point, causing a life-threatening situation for the person whose shunt is not doing its job. 30 or 40% of them, in fact, are estimated to fail within about 2 years after they get placed. That is a shockingly high number, if you think about it, for a device that helps so many people. 85% who got a shunt will require a revision at least once in their life. For kids who get shunts, we typically think of 2 to 3 revision surgeries during lifetime as the average number that people get. Although the greatest number of shunt surgeries that I've seen is over 150 in a single individual. Fewest number is 0, nicely enough. And we have our methods of evaluating shunts. So this is like a little peek under the hood in the neurosurgical black box of what we are doing with all those shunt patients, right? So obviously we're getting our clinical history and exam. We're looking for findings on the history or the exam that point to, is this a shunt problem or do you just have a viral illness? We get our imaging, but all these modalities, everything has its limits. Interestingly enough, 20 or 30% of kids, their fluid chambers in their brain, their ventricles, they actually don't get bigger when their shunt fails. And you might think to yourself, as many emergency department physicians might think to themselves, if the ventricles are stable on imaging, the kid must not be in shunt failure. Turns out that about a third of the time, a quarter to a third, that is absolutely not true. And so a lot of the evaluation and the attention that we place on shunted patients, if their symptoms are concerning to us, is because this is an unreliable measure. And in fact, every portion of the shunt evaluation is an unreliable measure in isolation. And like many other things that all of the other services, all of your services work up, it requires a composite clinical assessment. So sometimes we poke needles into shunts. If you're wondering why we do it, if we need extra information, sometimes that tap is helpful, but that tap is interpretable on its own. It can lead, it could give us confusing results. We can sometimes take kids and do nuclear medicine shunt flow studies. So they're injecting a technetium radiotracer into the shunt system and then seeing if it physically moves down. And let me just put this thought in your minds that sometimes getting a scan as fancy as this one, right? Just so we can have a poor assessment if stuff is moving through this plumbing system, it's important enough at the times that we do get it. It's important enough that we ask our hospitals to transport nuclear radioactive materials. We inject radiation-inducing materials into kids. We perform puncture access of a system that we never want to touch if at all possible, possibly introducing infection. We cause pain. We sometimes have to keep patients in the hospital for days before the radiology or nuclear medicine department is able to perform that scan on a weekday. So there's a lot that we will go out of our way to do just to get a pretty vague, not so great assessment of flow through shunts, which leads me to our question that even though shunts are plumbing devices, why is it that looking at the flow through shunts, like the actual movement of fluid through these devices, why is that not a basic part of our assessment? Not to say that that's the end all and be all of understanding shunts, but it seemed as if MRI had solved this problem of flowing fluids a long time ago. So just to recap, shunts have been evaluated in about the same way for a long, long time. And we do all this stuff without knowing how much fluid's going through there. And it stands to reason that knowing how much fluid is moving could be useful. If we had a method to be able to easily get fluid movement through shunts, why would that help? Well, it would help us clinically, potentially. It could help guide families and counsel them. If you knew how much was moving through shunts, instead of it being a total black box, you could possibly design better shunts. And also, there's this whole physiology chapter in a textbook that hasn't been written yet on CSF flow physiology and shunted hydrocephalus. This is a non-existing chapter because we've never had a method of investigating this in humans on a routine basis, on a large scale, in a repeated fashion. This just didn't exist. And so it excites me from an academic perspective that this is a book chapter yet to be written about a basic element of pathologic human physiology. So as I had mentioned before, seemed like MRI had already solved this problem. There's this technique, which is the same basic technique that goes into what I had shown you on the Chiarelli slides. Phase contrast MRI was developed in the 80s, and we use it for cine flow, like that picture I showed you before. Cardiologists use it very, very routinely in a very important, helpful fashion to do cardiac MRIs and look at fast flow of blood through the chambers of the heart. It is, in contrast to that other pulse sequence that I showed you, and again, I don't want to lose anybody with pulse sequence diagrams. I know I've already lost Jenny. It uses this orange thing to do the thing it needs to do. So the orange thing, for those of you science nerds in the audience, it's a bipolar gradient pair that sensitizes your scan to the velocity of flowing spins, which, that said, it adds one more little gradient going back and forth. And so we wanted to know if we tweaked up and sort of specifically cued this pulse sequence, again, not a new one, something that's already been around for a super long time. If we did this, could we see fluid moving through the tiny little dimensions of shunt tubes? So we built a phantom, we put a shunt tube inside an Nalgene bottle. This is also not super challenging. And we put it in the MRI scanner driven by a flow pump. And you can see this picture here is the shunt tube. It is ultra tiny. The inner diameter of most shunt tubing is 1.3 millimeters. And lo and behold, we saw data. And that was really interesting, again, because we don't do this clinically. This is an example of matching the fluid rate that you flow through the pump to the measurements that we're getting out of the system when you do an MRI. These are actual images inside the shunt lumen just blown up. So you can physically see fluid moving at different flow rates. And in fact, if you drew a little set of regions of interest across the diameter of the tube lumen, and then you got the measurement within each one of these tiny little voxel boxes, you can actually see a laminar flow profile inside the tube, which is just really neat. So we started doing this in people, and this was back over at CHLA, but again, we were really interested to understand why we weren't already doing this. And when I present this at conferences, which I have for the last 1.5 to 2 years, a common question I get from the audience is like, why haven't we not been doing this? Like, this doesn't make any sense. It seems really basic. And my answer is like, yahan, more or less. So turns out there probably was a reason. We as neurosurgeons have watched many external ventricular drains from patients in the ICU flowing, and we've also seen their fluid movement bopping around and pulsing. Every neurosurgical resident has stared at multiple external ventricular drains. We all know that the fluid is a little bit chaotic. Taking that understanding and looking at it through the lens of an MR physicist, we understand that this type of a pulse sequence that we're trying to use, if the fluid is not moving in a fairly continuous and bulk forward fashion, if instead it's shaken back and forth, like sort of the waves crashing into the shore, instead of the slow tidal movement of the currents in the ocean, then you're going to have a problem. And our hypothesis was that on the brain side of the tubing system, you would both have movement of the CSF through the shunt, but at the same time, you'd have this superimposed chaotic back and forth movement from the CSF pulsatile waveform. And lo and behold, when we tested this hypothesis and we got the same measurements in the same individuals, both multiple places on the brain tube, the proximal catheter, and multiple places on the other side of the valve, which could act as a pulsatility dampener. Because if you look at these valves, like if you just stare at them with your eyes, you realize that they have these silicone septa that as fluid is flowing through them, the septa don't let fluid move backwards, first of all. And second of all, it's dampening pulsatility just by having a floppy silicone piece in the way of your CSF moving forward. And what we found, and these data are matched between individual, if you take everybody who you see a little square here for, and then you look at multiple spots along the distal catheter, you see on the proximal catheter, between individuals, there is no rhyme or reason of the relationship between what you actually might be measuring and what you would be measuring otherwise. And so this kind of confirmed that hypothesis. And then we went on to find individuals who had their shunt system externalized because we wanted to know, is this accurate? Like, sure, it's accurate in an Nalgene bottle, but is it accurate in a person? So we had to find kids who were externalized at the clavicle, and that is harder than you think. Typically, you need some sort of ruptured viscus or some situation where the shunt itself is not infected, but you'd like to get it out of the abdomen or the distal cavity for some reason. More often than not, because we follow IDSA guidelines for shunt externalization in infected patients, most shunt infections would have a full system externalization, meaning you take out their valve, you take out the distal tube, the proximal tube, you swap it out for an external ventricular drain. The problem there is that you're back in that situation where you don't have a valve as a pulsatility dampener. You need that in order to actually simulate the situation that a patient would have with a real shunt. We would like to get an MRI measurement about here in a person, and we'd like above it to still be a valve and a proximal catheter, and below it to have a tube that came out of the skin near the clavicle so that you could count how much came out into our little collection burette. And so we did that, and no shocker here, we got the same amount coming out as what we had measured with our technique. We did this in more individuals than one. We found that no matter where you do your measurement along that distal catheter system, turns out you're getting about the same number. We also added in this, if you were to try to measure proximally, this is basically why people attempting this in the past, why it didn't work. And then we started collecting this data in patients. This was actually so overwhelmingly heartening to the neuroradiology department at CHLA in Los Angeles that they basically added on this flow sequence to the routine fast or limited brain MRI that we were getting for kids who had shunts. So anytime at CHLA, a patient came in who had a shunt and they were getting a routine MRI 1-minute scan or 5-minute scan, this would be a 1-minute sequence that was tacked on. And we didn't have to request it, it would just happen. So we started collecting data as a result of this. And we have about 700 patients scanned over there. And in fact, one of the first things I did when I came here in September is we had a similar discussion, and Phoenix Children's now collects the same data. This data is only available, just to be clear, at Phoenix Children's Hospital and CHLA, although every major subspecialty children's hospital, every tertiary care center in the world who has pediatric neurosurgery, who is familiar with the happenings in the country, they have been on my case to talk to their MR physicists to get them this type of sequence. I'm being very cautious in the way that I roll this out clinically, because anytime there's a new clinical variable or a new piece of data available, there could always be unanticipated consequences, even if it seems super benign. So I'm being a little bit cautious, but just to kind of clue you into, this is something we actually have. I've had clinical partners here on neurosurgery service who ask me on a not too infrequent basis, like, hey, Peter, I got this challenging case of a patient with a shunt. Can you help me get this measurement? Can we make sure to just do it for this kid so that like maybe that can integrate into their clinical care? So that is actually a real thing that happens here now. And you are now looking at data that did not exist in the world beforehand. This is about 300 of our patients, and this is looking at a plot of age versus their shunt flow. And we're not discriminating between type of shunt, where the shunt's located, how much flow they're actually making. We're just saying in all comers, what does shunt flow look like? If you were to make a histogram of shunt flow, what's the average flow? Like, these are just simple facts about shunted hydrocephalus that the world didn't know. So you, with your eyes, are looking at the world's first histogram of shunt flow, like agnostic to shunt valve setting, agnostic to system. I can tell you that in boys, the most common flow rate is about 8 to 10 cc's per hour through shunts. And that sounds like a very simple fact, but it is not an element of understood human physiology before this. So that's neat. We're doing more advanced statistics. Obviously, we're doing multivariate regressions and models using machine learning and all sorts of other fancy bells and whistles. But let me show you something that for me was actually the most impactful finding that we had so far. The reason why this finding is shocking to me and why it could potentially be one of the most important developments in hydrocephalus for decades is because we as neurosurgeons, as we're doing our residency, as we're looking at external ventricular drains in the ICU, we see different amounts coming out of those things every hour. Every single hour, sometimes it's putting out 1 cc, sometimes it's putting out 20 cc's because they coughed or moved in bed. So I've never met a neurosurgeon who had a pre-existing suspicion that if you checked shunt flow at 2 different times in the same patient, that there would be anything resembling similarity. It's flowing however it's flowing, it's probably flowing different now than it is an hour from now. Well, it turns out that because we were collecting this data, we had pairs of scans in the same patient. So on the x-axis here, each S is a subject with shunted hydrocephalus, and they received 2 scans for routine purposes. None of these scans were during shunt failure. These were all asymptomatic clinical follow-ups. And for whatever reason that they got the scan, as long as they were not suspected to be in shunt failure, we marked here the amount of time between the 2 scans. And whether that was a year or a month, there was a startling amount of similarity between these bar graphs. So much so that if you plot scan 1 on one axis and scan 2 on the other axis, like 0.98 for an R-squared value is as linear as I could ever ask for. This is very interesting because all of a sudden, this suggests something new. And again, this is the intersection between engineering and clinical medicine. All of a sudden, shunts, which are challenging sometimes, easy at other times, shunts have never been approached with an idea of quantitative data in an individualized patient care model. Meaning, if you knew an individual patient's own baseline for shunt flow, could there be a clinical scenario where that baseline matters for that patient? And if you saw a change from a patient's own baseline, not that you want it to be the same as another patient's baseline, but if you saw a change within that individual from their known baseline, could that help you clinically? So here's some examples. This is, for me, again, the heartening part about wearing both clinician hat and science nerd hat are plots like this. This third one here, I won't belabor the point and show you all of this. Let's just focus on this one. This was a patient who had received a baseline scan. And at one point, they came into my clinic. It was actually 2 years later with this little red caliper. They came into my clinic, and there was just a random quirky mention of something that the parent had mentioned about a lymph node. It wasn't something that would have raised otherwise eyebrows. Ventricle size was roughly the same. There wouldn't have been any reason to do anything other than, okay, I'll see you in a year. It seems like you're fine. A primary care doctor had mentioned something about a lymph node to them. I asked my lab team member who was getting the scans analyzed. I said, hey, can you take a look at their shunt flow for me real quick? I'm just curious about something based on that. Lo and behold, at that moment, which I labeled as symptomatic, but again, there was no other symptom, the shunt flow was about 40% less. And these were in the early days. And I didn't know how much I could or couldn't trust this measure. So I said, listen, on the off chance that this lymph node is actually a tiny little CSF collection, the lymph node had already gone away, by the way. In the off chance that it represents a little CSF collection, maybe due to a pseudomeningocele caused by a fractured catheter, let me get a series of x-rays. X-rays are cheap, they're easy to get. We get them all the time for shunted patients. I made a very valiant attempt not to change my clinical management based on this test, but that could have been something I would have foreseeably done otherwise anyway. I got that x-ray series. Lo and behold, the catheter had completely fractured. The distal segment was floating freely in the abdomen, not at all connected. It was about multiple feet separated. That child had a patent tract with CSF allowed to run through their soft tissue cuff down to their abdomen. But as we all know, those tracts close, and they can close in the middle of the night, one random day, and they will immediately go into shunt failure, which will represent an emergency situation for that kid. So basically, we were able to fix the situation during the light of day, weeks or months in advance, and avoid an emergency for this patient. There are other examples where we avoided unnecessary surgery as a result of this scan. This fourth one is really cool to me because it actually allowed the neurosurgeons to operate on the correct side of the patient in a clinical scenario where, for reasons that I won't describe, there was just indecipherable information for a patient with bilateral shunts, which had been the one that was working before. So pretty neat. So as the work has progressed, a lot of neurosurgeons around the country have asked, hey, can we do this too? Can we put this on our MRI scanner? So as scientists, we actually wanted to get answers to these questions. So I had a student who did this as his senior thesis project for undergrad. We work with a lot of undergrads in the lab. And we wanted to look at every variable under the sun between MRI scanners. And I'll kind of jazz it up with some color because now that I'm talking about multivariable scanner calibration studies, I'm going to lose every single human being in the audience. So here are some fancy plots. We made them on MATLAB. They are very cool. But we came up with both multiple ways of analyzing the data better. And also we put this through every scanner that we could find in Southern California. So we put it on 10 different scanner coil combinations, and we tested like thousands and thousands of scans on the Nalgene bottle version so that we could keep everything consistent. And we ended up with a whole slew of data. And again, all this stuff has been submitted, so it's in the review process right now. But we could see that if you get fancier and fancier, you get better and better in the way that we measure. So we're getting reliability in the way that we do these measurements at the same time as we're able to tell clinicians around the country when it comes time to run this on a Philips, Siemens scanner, 1.5, a 3T. We actually have data at 0.55 and 7 Tesla as well. Turns out you can do it on all of those scanners. Also, shunts have different catheters. So some shunts have barium catheters. Some shunts have different coatings or impregnations on the catheter. Turns out that doesn't affect the reliability of the result much either. And we tested a number of other variables, the tilt of the slice in the scanner, the shim quality, a whole bunch of other things. So we're able to get more reliable in our ability to measure this. I'll skip that. We're also developing an automated method using AI so that a human being from radiology does not have to do an extra analytic step. The machine will just basically take the scan output and give you a number. So as we were doing this, we were curious whether or not there was another way to do it too. This was the world's first non-invasive quantitative way of looking at flow through shunt systems. But we also had an inkling that instead of phase contrast, which is this, remember the pulse sequence, the bipolar gradient pair, the thing that you guys were loving what I was saying? Remember that first sequence that I showed you in the Chiarelli patients? Remember this timestamp method where we put a tagging slab, we wait a little bit, and then we see where the tagged spins go. Could you use that to also look inside shunt tubes? So we tried that, basically putting our tagging slab across the lumen of the tube, doing the same approach as before, where we started with a phantom inside the MRI scanner with flowing fluid. And lo and behold, that not only could you measure the flowing fluid, but using this method, you could actually come up with these beautiful visualizations. So you're physically watching fluid flow here inside the lumen of a shunt tube, identical hardware to what we use in the operating room, at like, I want to guess that this was at 10 or 12 cc's per hour for this example. You can imagine that in patient care scenarios, being able to show a family an image like this could actually provide clinical value. If a family is like not necessarily on board with the clinical assessment, if there's any like sort of question or curiosity, imagine the sort of the bonding element of that clinical interaction by being able to say like, picture's worth 1,000 words. Have a look at this. It turned out this method was also reliable at multiple flows. You could come up with line plots and graphs. You can get even fancier and make those line plots in MATLAB so that not only could you see the fluid moving through the tube, you can see this is the decrement in the signal intensity of that inversion recovery tagged spin. But you could also see it across the profile of the tube. So these little humps on these different contours here, that is the 4 voxels across the actual diameter of the tube lumen that you're seeing the laminar flow profile as the fluid is flowing. So we start collecting human data with this other method. And intriguingly enough, forget about this patient here. There's a reason why the 2 values were different. Just selectively ignore that one. But lo and behold, the 2 methods were telling you about the same thing, which was useful for us scientifically because we wanted to know if there was ever a need to validate one method internally without having an internal reference. Could we validate one method with the other method since they were using entirely different spin physics? The answer to that was yes, but it was actually, yeah, this was me telling you to ignore that one. Feel free to ask me afterwards. I don't want to belabor the point. But lo and behold, there was actually something more interesting when we started using this second method of getting to the same data, that the amount of variability within patients, the variability was significantly high. And remember, we're looking in the distal tube. After flow has already been dampened, post-valve, it should be nice bulk flow based on everything we understood so far from the phase contrast measurements. Instead, here's a value of 0. Here's a value of multiple different things. This patient has a dramatic spread of all their values. And like these are those values plotted over time. So you see that these values are bopping around all over the place. We thought this was smooth, continuous flow. Turns out that this is showing you the same reality. Remember that the average of one technique and the other, except for their little red line plot here, the average is the same in both cases. But what this is doing is showing you snapshots at various instances rather than averaging over a whole minute. What this means for me as a clinician is that there's actually still a lot of residual pulsatility inside the distal catheter of patients with shunts. And this could be meaningful. So we have based on this data, there's actually a collaboration that we struck up with researchers doing hydrocephalus work with computational flow dynamics at University of Washington, another researcher at Wayne State. The 3 of us are working right now on a collaborative R01 grant that we're going to be putting in July. But using this type of data in a computational flow dynamics simulation to take patients' real data and to possibly uncover hidden variables that are actually causing the shunts to give you problems. Just an example of that. What we're starting to realize is that the moment that your CSF bounces up in terms of its pulsatility, right? Your CSF waveform in your brain is pulsing all the time. And at that peak pulsatility moment, people have taken little cameras and looked inside shunt tubes. And it's at that moment that the choroid plexus or the ependymal surface gets drawn into the little holes in sort of a bouncing pulsatile fashion. If there are ways to understand that pulsatility and to potentially dampen it using more rational shunt hole design, valve design, other things, tubing configuration, you can actually attack the root cause of the problem, AKA pulsatility, that's actually causing shunts to fail. And that's where we get to can you use this information to actually just improve shunts overall? Same thing with over drainage. I don't know if you know about it, but some people with shunts, they have problems where every time they stand up, they're draining too much. And we've solved that problem for decades with the attempt at using anti-siphoning devices, meaning if your tube has gravity weighing the fluid and pulling from the proximal catheter, just like in your irrigation system in your landscaping, can you have an anti-siphon in order to, when you stand up, prevent that sort of pulling motion from the distal side? Instead of and anti-siphons have been variably useful, sometimes not useful for certain patients. The thought being, if pulsatility is part of the cause, if peak pulsatility is causing individuals to overdrain, can tackling the root cause of the problem in that instance also lead to clinical value? So that's that. So timestamp, useful, interesting methods. So let's conclude. So Chiarelli malformation and hydrocephalus are 2 very simple use cases. Again, we are focusing clinically on the bread and butter conditions because we want to develop simple innovations, things that are non-invasive, quantitative, that can be used in the common stuff that we do, not necessarily just the esoteric stuff we do. There are many more conditions of CSF flow that we tackle. So neurodegenerative illness and lymphatic flow, Alzheimer's disease. There are flow patterns in these conditions and emitting byproducts from the brain that can be studied in better ways, and people are starting to do that. Normal pressure hydrocephalus in older individuals, spina bifida and fetal hindbrain herniation. Like, why do we actually get Chiari-2s in myelomeningocele? We're finding out now that it's because of flow patterns, that you actually get these anatomic changes that affect you for life, all sorts of things. I proposed this at a national meeting. This is me sounding a little bit grandiose, but I mentioned to the group that I think that we are currently now entering the era of CSF flow, where clinicians are beginning to realize that this is key information that we've just sort of neglected for the whole history of our field. And as we understand it more, it is going to have increasing clinical application. We're actually developing clinical prediction models, like risk stratification tools, to quantitatively assess how much this is useful in clinical scenarios. This is the data we're collecting right now. We're also doing population-wide studies of shunt, or sort of demographic and anthropometric variables for individuals with shunts. We're also doing physiology experiments, which is pretty cool. Imagine a patient with a shunt or a condition that you treat where you develop a better non-invasive measure of measuring the thing that happens in the condition, right? You take a child who has shunted hydrocephalus and you get them to pedal on a bicycle ergometer in the MRI scanner. Or you do a challenge, you do a gas breathing challenge to change their end tidal CO2 so that you can simulate increased cerebral blood flow. Or you do a hydration challenge where they're not drinking first thing in the morning and then they chug a whole bunch of water to see what impact these factors have on the amount of CSF we produce, the amount of CSF that goes through shunts. Basically, the world is our oyster because any variable that could impact flow in hydrocephalus, wouldn't it be nice to know about? So all of that science can actually be studied now that there's just a simple method that you could repeat over and over again without, giving radiation or anything like that. So again, goal, just matching simple technological solutions with the real clinical problems. A big insight on my part, because I did my PhD before I went to medical school, a big insight was first thinking that science had all the answers, and then realizing that there are so many answers out there that clinical medicine has never seen. And it's extraordinarily impactful for me, and it's something that I'm going to take all my life, that in many fields, the science has outpaced the clinical utilization of the technological development. And I'll just venture to guess that that's true across all fields of medicine. MRI physics especially, because that's what I saw firsthand, that the amount of development by PhD students having zero idea how it would actually be clinically applicable had just, by a factor of 10, outpaced what clinicians were doing with all those technologies. So being able to put the two of those together, wearing both the sort of clinician and the researcher hat, this is my motivation in life as a physician scientist. But thank you very much for listening to me, and if there are any questions.
On the overhead mics. I'll start with one question. It's a little bit off the topic, but it is on the topic of CSF. When I was a resident, we did tons of LPs on babies because Prevnar wasn't out yet.
What wasn't out yet?
Prevnar, the vaccine.
Oh,
okay. So saw lots of meningitis. And so as an intern, first month, did 10 LPs or whatever. And we always took off plenty of tubes so that, plenty of CSF so they could, 1 mil protein and glucose, 1 mil for cell count differential. Then we usually got a few extra ones in case ID wanted any extra studies if there was meningitis. And never thought about anything about how much fluid we took off. Now, apparently, interventional radiology has protocols that's weight-based for how much is CSF do they remove. And sometimes the neurologists who order autoimmune panels want more CSF than the radiologists say they should get off. So what is a neurosurgeon's take on when an LP is done, how much CSF should be removed? And is there any reason to not get as much as, to get the diagnostic studies that the specialist wants?
So I really like that question a lot because a little bit of it is a black box, right? There's clinical guidance on how much CSF you should remove. Let me give you a specific case example. We place reservoirs in little preemies all the time because they're not sufficiently heavy body weight wise. in order to place a real VP shunt. So we put little reservoirs subcutaneously and we tap them. We have general guidance that we go off of how much CSF to remove from those reservoirs. Usually most neurosurgeons will agree on a number similar to about like 10 cc's per kilogram of CSF that you can remove, which actually sounds like a lot, right? Like if you have a 1 kilogram baby and you're taking off 10 cc's of CSF, like, okay, that feels kind of like a lot. Keep in mind, as older kids or as adults, we have about 150 or 155 cc's of CSF inside our neuroaxis at any given time. Little babies, obviously, proportionally smaller. But the amount of CSF that you can take off, that number, I'm pretty sure, has no hard data behind it. You know, in the classic neurology teaching, right? It's like you take your ICP, if you're doing an LP for elevated ICP or for other purposes, and then you half your number, right? So you take your ICP of 30 and then you take off just enough CSF in order to bring your number down to 15, because that's safe. As neurosurgeons going through residency, I would tell you that extraordinarily routinely, I went through residency during the era where we would lumbar puncture adult patients with subarachnoid hemorrhage on a near daily basis to avoid shunt placement and do a lot of what Dr. Ronecker just suggested. Because we knew we were tapping them every day, we would take off CSF like the Dickens. We would remove massive volumes of CSF on a pretty daily basis, more so than having the number of the ICP, because we knew that it was safe in that instance. And yet you'll get into other situations where a patient has cerebellar tonsillar descent, they have a Chiari, maybe they have a brain tumor, there's a concern for elevated intracranial pressure or a difference in pressure between compartments where, let's say the pressure is already high here and you're moving CSF down there, is there a possibility of causing them to downward herniate through the foramen magnum? And we take that pretty seriously, because if we have a patient with profound cerebellar tonsillar descent, we might not allow them to be lumbar punctured at all. There's also a lot of history about whether or not we lumbar puncture babies with hydrocephalus or a concern versus placing reservoirs or doing, transventricular taps. So there's a whole bunch there, and I'm not going to give you a perfect answer to that question. But whatever you're doing, you're probably not wrong, and there's also not data to support it.
Alex, I'm pediatric surgeon, so we get to work with you guys related to this topic for kind of the distal portion of the shunts and revising or putting new areas, putting them in new locations. Have you studied at all the difference in flow, whether the end is peritoneal, pleural, or atrial yet?
Yeah, so we do have data from V pleural patients and peritoneal catheters, pleural, atrial catheters. In terms of function of the method works regardless where your shunt is going. It's intriguing to us as neurosurgeons because we, in a hand-waving, vague way, we think about these different compartments as having different flow dynamics without saying those words. No neurosurgeon will actually say flow dynamics to you, but sometimes neurosurgeons will say, oh, well, I kind of want them to siphon a little bit more CSF, so I'm going to put a pleural catheter in, right? Because the pleural cavity is under negative pressure from the chest wall expanding, right? This is something that we do say to each other as neurosurgeons, but that is definitely something to study. Like, we can study that now because when we have shunts in different compartments, we can both measure their real-time pulsatility dynamics and also their average flow rates between individuals. So yes, and that's cool. I don't have any concrete answers for you yet, but that's definitely something to study.
I got one more, just area of study. How about kids with constipation and shunts?
Yes.
Are you studying that?
Yes, I am. So this to me, remember when I mentioned at the very end, the physiological modules, right? Constipation and shunts is that, for me, it's that perfect balance of simple, trivial situation, which doesn't really have good understanding or fundamental science behind it, right? We understand that shunts have to deliver fluid from an area with a pool of fluid to an area that represents a pressure sink, right? This is like basic thermodynamics, where you need that pressure sink on the other side, or temperature sink in thermodynamics, in order to allow stuff to flow from one compartment to another. If the pressure sink, the abdomen's under high pressure than what it typically is, then it's no longer acting as a pressure sink, it's acting as a resistor. So how much does abdominal resistance, does it contribute in an additive way to the valve resistance in the same way that, if you have two resistors in series in an electrical circuit, that you're going to, summate their resistance to one another when you're calculating their little V equals IR. Sorry for that, for everybody. But yeah, so with that in mind, you can study that. And one of the ways that it comes into impact for us that I think is the most significant is in little tiny babies who are in the NICU, they're on a ventilator. And that ventilator is increasing your intrathoracic pressure, which then transmits through the diaphragm into their peritoneal cavity. So you'll see kids on a high PEEP in the NICU having a poofy belly, and for a fact their shunt that you've already put in is encountering higher resistance because of the ventilator settings. So similar to constipation, just different scenario. We are studying kids. We're recruiting patients right now. This version of this experiment's happening right now at CHLA, but we have a little fancier version that's going to start up here with our clinical research coordinator, where we're just putting little weights on their tummy. So we're putting graded weight with little bean bags on the tummies of kids, and we're seeing how that affects their shunt flow, which sounds really basic, but nobody's done it before. So I think that's very cool. And it's going to simulate things like constipation or abdominal girth or all the other things that could potentially cause you to, in advance, know about those things and potentially implant a different shunt system or a variable, programmable valve or something like that as a result of knowing that.
I think we're at time, so I have to let the residents get back to the wards, but thank you all much. Comments are thank you and really cool work.